Hi, I'm Dr. Jack West, medical oncologist in Seattle, and also the founder and president of GRACE. There have been some real developments in first-line treatment for the subset of patients with what's called an activating EGFR mutation. This is a mutation routinely tested for in patients with non-small cell lung cancer, at least the non-squamous subtype. And patients with stage 4 or advanced EGFR mutation-positive lung cancer are typically treated with an oral inhibitor of EGFR, which is a molecule that has this mutation that seems to be enough to cause the cancer to grow and divide. Now, there are several potential agents, one called Iressa or gefitinib, another called Tarceva or erlotinib, and another called Gilatrif or afatinib, that have been around and FDA approved for a few years, and they all show relatively comparable activity. That is, the likelihood that a cancer is going to shrink, which is really very good with these agents. If you have an activating mutation in the EGFR gene and you get one of these agents, your chance of the tumor shrinking is about 60, 70, even 75%. And they tend to last for a long time, at least by lung cancer standards, so that typically patients are going to go 9 months, 10 months, 12 months, or sometimes longer before their cancer develops a way around these drugs and then begins to grow again. Typically, patients will live years with these agents and then subsequent treatment options. Now, the world has potentially changed, and I would say should really change based on the results of a new trial known as FLAURA that was just presented in early September of 2017. And it has implications in how we're going to treat patients, because historically with these earlier EGFR inhibitors, they've produced largely interchangeable results, some modest differences in activity or side effect profile, but nothing major. And so it's really been a dealer's choice based on preference and tolerability issues and general experience and comfort, which of these you might recommend for a patient. So this trial called FLAURA randomized several hundred patients with an activating EGFR mutation who had not received prior treatment to either a standard of care first generation EGFR inhibitor, that is Iressa or Tarceva, or as an alternative, the third generation EGFR inhibitor Tagrisso, also known as osimertinib. Now, osimertinib is FDA approved as a second-line treatment after patients have progressed on one of the first-line agents, but only in the subset of patients, about 50 or 60%, who have what's called a T790M mutation, which is seen in about, as I said, a little more than half the patients when their cancer progresses, whenever that is. And this agent Tagrisso can be very effective, at least for several months, sometimes beyond a year, but the question is whether it's better to give one of these drugs, to give Tagrisso in the first-line setting, and maybe go even longer than you'd otherwise get by doing one followed by the other. So the FLAURA study was just released in a preliminary analysis that showed a very significant improvement in progression-free survival in the patients who started on osimertinib, on Tagrisso, compared with those who started with one of the older EGFR inhibitors. In the patients who got Iressa or Tarceva, the median time of progression-free survival, the time before half the patients progressed, was about 10 months, which is exactly what we would expect to see. But it was about 19 months for the patients who received and started on Tagrisso. Importantly as well, we saw a trend toward better overall survival even in the patients who started on Tagrisso. This was an early and immature analysis because most of the patients were still alive. That's a good thing. But it's encouraging to see this strong trend toward actually better survival in the patients who started on Tagrisso compared to those who started on Iressa or Tarceva. As well, there was a difference in side effect profile that favored Tagrisso. lower incidence and lower severity of rash and irritation of the liver. So this also favors Tagrisso. Now, at this point, the FDA has not approved Tagrisso in the first-line setting, that is, as of September 2017. But it is likely, I would say, that the FDA will approve it for first-line treatment. And my inclination is going to be to have my patients newly diagnosed start on Tagrisso from this point forward. I think it's much more debatable whether we'd want to switch someone already doing well, who is already on Iressa or Tarceva or Gilatrif, from that to Tagrisso. But it is worth noting that Tagrisso has very good activity against brain metastases and protecting against future brain metastases, and that would lead me to kind of favor getting that started as soon as possible. Importantly as well, we know that if 40% or more of patients, when they progress on a first-line treatment like Iressa or Tarceva, don't have T790M, they might never get the opportunity to receive Tagrisso. But if you start with it, 100% of patients will. So I think that it is very likely this is going to substantially change the first-line setting. It's a convincingly better result with Tagrisso, and it's enough for me to change my practice and favor using that as my go-to first-line treatment from this point forward, or at least as soon as I can get it covered by insurers.